Hello and welcome to this King's Fund online event, today run in partnership with InterSystems. Our focus is on sharing health and care data and the benefits of interoperability for patients, staff and carers. I'm Kieran Cornwell, I'm the Head of Events and Partnerships here at the King's Fund, and I'm delighted to be joined by a fantastic panel of Lorraine, James, Shauna and David. And Lorraine, starting with you, would you mind briefly introducing yourself, please?
Thanks, Kieran. Yes, I'm Lorraine Foley, Chief Executive of the Professional Record Standards Body. We represent all of the health and care professions and patients and people, and we work together to define the content of information records, absolutely the bedrock of interoperability, so delighted to be here talking about this today.
Hi, I'm James Palmer. I work at NHS Digital, where I'm leading a programme on adult social care technology, which is the aim of catalysing the digital maturity of the sector, both in local authorities and care providers.
Hi, I'm Shauna McMahon. I've worked for 15 years in healthcare in Canada. I came to the UK 3 years ago to serve as a CIO at one of the foundation trusts, and just recently I've started a role at the South Central and West Care Commissioning Support Unit in digital transformation.
Hi, I'm David Hancock. I'm a Client Engagement Director at InterSystems. InterSystems are our supplier of integration, interoperability and EPR software. I also sit on the Tech UK Health and Social Care Council, and I am the Tech UK representative on the Interopen board.
Great. Well, thank you all very much for joining us. And thank you to you all for tuning in and watching live wherever you may be. We've got a great group of people signed up from all parts of the health and care sector, not just in England and the UK, but internationally as well. So wherever you're watching, welcome and thank you for joining us. Just to talk through our plan for the next hour. So we're going to start off with a few questions I've got for our speakers, which is just going to help get the conversation started, also place some of the issues and topics into context, and then we're going to look at the questions and comments that you're submitting. And in order to do so, if you have a look on the events online event portal, you'll see a box that simply says ask a question, type away, send it across, and then we'll get through as many of those as we can later on. And I'd encourage you to start sending those across right now. Don't wait till we're on to those questions later on. Finally, regardless if you're watching this live or on demand, I'd encourage you to continue the conversation on Twitter using the hashtag KFOnline. Okay, so on to our questions. Lorraine, I'll start with you. So why is interoperability so important?
So interoperability for me, Kieran, is about the safe sharing of information. So what we send is what's received, and we all understand the same thing by it. And that information is absolutely a critical component of care in the same way that vital signs are or any other aspect of patient intelligence. And in a modern, complex health and care system, very many different people and services and settings can be involved in our care, not least ourselves. And so for me, it's important because having that complete, accurate, relevant information readily available is absolutely critical. In fact, it's fundamental to safe care. So for that reason, it's absolutely critical in my book. And an example of that, I see lots of really good examples around the country of I saw a paediatric team in Rochdale with an integrated care record, which is a sort of fairly simple version of interoperability, but we're sharing information really productively and talking to the OT and the physio and the advanced nurse practitioner and the GP. Their ability, they were talking about a child who'd had a stroke, a young child, and then had the physio was dealing with the physical disabilities, and then he was on medication for epilepsy, so they needed to adjust the stair rails or whatever. What the staff said, and the reason this is so important, is that having that access to the information, being able to see at a glance everything that's going on that's important for this child, enabled them to give great care. As a parent, I'd be delighted with that. That's why it's important.
Excellent. And Shauna, to come to you next. So we've been here before, haven't we? So why do we think we're going to be successful this time?
I was reflecting on that question, and one of the things that stood out for me is there's no time, I think, in any sector where the importance of accessing information has been realized. And you think about Facebook and these Twitter, it's all about information. We often focus on technology, but that's just the bottom of the thing. The ability to share information is key. I think what's important this time is throughout the UK, all of the events I go to, reading Matt Hancock's new vision, at the heart of everything is about interoperability and sharing. And for the sake of, as Lorraine said, safe care, quality care, also better decision making, and using the funds that we spend in a better way. We've never been at a point where we could bring together all these data elements and have really informed decision making. And I was just talking with Dave just before we started. And in the U.S., there's a group called the CareWell Group and the Care Quality Framework. And they're a consortium of Cerner, the Allscripts, the Epics, InterSystems, and they've now just this month are ready to start sharing information across those two groups. So I think when you see that coming forward, you know that the time is right. And the other thing I find in the UK here, the integrated care system, when I think about that, integrated by that word means we have to have information that's agile, flexible, that we can receive and treat people in a safe way. So I think the time right now is just prime for us to really get the interoperability we need.
Thank you. And James, to come to you now. So what do you think we need to do in order to get social care more involved with this agenda?
I think for a start, we need to, and this is going to be a not a tech answer, it's need to start having appreciation of what we mean when we say social care, and to really get underneath the bonnet of the complexity of those two words. We wouldn't be saying health without knowing that there's mental health, there's sexual health, there's community health, there's acute, there's planned care, there's maternity pathways. We tend to have these great big pictures that says, here are the blocks of health, and then in the corner we'll have social care. And that in that, we have to understand the roles of all the players. So local authorities are very different from care providers themselves. And like we've learnt within the health system, we have to talk to the people who are actually buying and using the IT systems and using the information to get on top of it. So I think it's about embracing a whole different conversation with the sector, and also understanding where they are right now on the digital maturity pathway, and understanding who their IT suppliers are, because we don't have as much of a knowledge base and history of working with them as we have with perhaps some of the health systems.
Thank you. And David, to bring you in, we hear a lot about global digital exemplars, GDEs, or local healthcare record exemplars, LICRAs. What role do you think they've got to play in the adoption and spread of sharing health and care data?
Well, Kieran, I think they've got a huge role to play. If we kind of look at some of the issues around why we haven't been so successful in the past, I think we can sort of see a number of factors, which I think, with the GDEs and the LICRAs sort of properly organised and set up as they are now, will actually help us overcome. In the past we've had, I would suggest, too many of these initiatives and these standards implemented top down. And the problem with going top down is that it doesn't take account of the huge variability of endpoints, i.e. the systems, and how interoperable they actually are, because some are really very uninteroperable, so they can't even manage some basic things. And that's just a fact of life. Some of them were built 25, 30 years ago. They weren't built to be able to do any interfacing. So you've got that high degree of variability, which means saying something top down, we're going to do this, is not taking account of what's happening on the ground from systems. The second issue is that not all local health economies have got the same priorities. So just because the centre says, I've got these priorities, this is what I want to be able to do, I could be in a part of the country going, that's not important to me because with my population, with my particular demographics, the issues I've got, this is what's important. So hopefully with the GDEs and the LICRAs, they are being given specific amounts of money to allow them to be able to focus on what's important for them and to be able to then define what they want to do. So what I would hope these would do is these would be able to define the interoperability they want to achieve. They would in fact begin to define the way in which that interoperability would be done. So they would, for example, would be able to work directly with Lorraine at PRSB to be able to say what is the records we want to be able to do, then how will we be able to model that to be able to come up with the actual interoperability standard. But again, the beauty of being able to use a LICRA and a GDE being nice and local is if they've got local and they've got the need, they'll also be able to identify the first of type to go and implement it. Again, another issue we've had in the past with top-down is that gone, let's go and define this, and let's go, without thinking about who's going to be the first organisations to go and try this out. Because you could be damn sure that the first time you try it out, it's not going to be perfect, it might not work. So I'm really hopeful this combination of the local things with the LICRAs and the GDEs will really be able to break through that and allow us to be able to achieve the things we haven't been able to do in the past.
Excellent. Well, a lot to be optimistic about so far, and I'll just briefly pause on our questions to our speakers just to say thank you to everyone who's already sending in the questions that are coming through to me on the tablet, and just say if you see me looking down, I'm not being rude, I'm just having a look through your great questions, and I just encourage all of those watching online to continue sending in those questions, and we'll be going to come into those very shortly. Just to pick up on a couple of points, We've heard Interopen, we've heard Tech UK and about some of the suppliers, and obviously these suppliers have an extremely important role to play within sharing health and care data. Is there more that needs to happen at this point in order to get suppliers involved? Shauna, you mentioned some of the things that you've seen in the US. You know, is there any lessons we can take from there?
I think it probably goes back farther than that. I remember being at a conference and there was a physician talking, and he said, you know, we've structured medicine around body parts. And we're in an age now where we live longer. We come with multiple complex health issues. And also there's a consumerism in our, amongst the general public, who aren't just going into hospitals or community centers or accessing care in other avenues. They're going to looking at, you know, massage therapists, all kinds of different ways to get healthy. And so I think from that perspective, the vendors themselves are recognizing that they have to deliver. And, you know, you look at Google, Amazon, all the others getting into the market, they are pushing to adapt to what consumers want. And we're all consumers of technology, and we're very demanding. So I don't think, and some of us might be in the group that we have not only children, but seniors that we're looking after, and we have to have a shared way to get the information and deal with that. So.
Excellent. Well, yes, please, David.
If I could come in as well on the suppliers, sort of with a supplier hat on. I think one of the things that we need to recognise is that we can come out with ways in which we want to be able to do interoperability, but we can't expect the suppliers to be able to turn it on like a tap. So we need to be able to work with the suppliers and recognise that they've got a whole load of things that they've got in their product roadmap. And if we want to be able to include these other things we want them to be able to do, that's fine. But they need to be able to, well, if I'm not going to do this, there's something else that I've got to take out. They've got to be sure that also, well, is it going to be used? Because if they want to make sure the investment that they're making in those things in their roadmap are things that are going to give them a return, to be honest. And that's the same with any kind of organisation, whether you're in open source or what have you. You want to know it's going to get used. So we've got to make sure that we're working collaboratively quite early to be able to help define those and make sure that they're being developed in a way that the majority of the suppliers can work with. They can plan it into their roadmap, and then they can be ready when the service says, and now we want to be able to use it.
Can I add to that as well. I think that's spot on, and what we all need to realise is this shift to standards and hence interoperability is a really big cultural change. And we're just hopefully getting to a tipping point, but the vendors and actually everyone else we need to build belief that it's not, flavour of the month this month and next year it'll be something different. So actually I think everybody needs a roadmap, and they need certainty and confidence that this is going to continue and it's inexorable.
And from thinking of around the social care, and particularly the social care providers, I think we have a tremendous opportunity. There are 24,000 social care providers in this country across care homes and domiciliary care. And a lot of those are very small organisations, but they're all customers. And I think really supporting that community to have a dialogue with their suppliers and sort of talking openly and honestly about some of the ways that we've worked with health systems over the years, some of the things that have been great, some of the things that haven't been so great, is something that we really need to get started. And last week we actually announced a new service which is investing and working with care providers themselves to start that conversation. And I know that some of the system suppliers I've been talking to, they want to start conversation about their roadmap, and they want to say, actually, we can help you build a system for the future, not necessarily build you the system that's going to solve your problems for today. And I think particularly with social care, there's the opportunity to perhaps jump forward and build on that. So I think there's a tremendous opportunity over the next couple of years, particularly with the tech vision presented by the Secretary of State, giving a kind of underplay as to how we might do that. So I hope to see a lot more action in the year forward.
One thing I might add, and I hope this isn't controversial for anyone, but it was actually mentioned in a recent King's Fund newsletter a couple of weeks ago, and that is, we talk about interoperability, but one of the things I noticed when I came to the UK, and I don't want to generalize, but it does come up still when I talk to some of my CIO colleagues, is the just fundamentals of the IT systems that need to be in place. There's a lot of disparity in the UK, and you asked me, Kieran, about the difference in Canada and the US. I think in Canada and the US, years ago, we all got our technology up to a certain standard. And when I came here 3 years ago, I have to say I was really surprised at the disparity of the technology. I mean, I've used Skype for Business for years in Canada. We had all single sign-on across 8 hospitals in our community care centres. Here, come over, there was no Skype for Business, no single sign-on. Some of the data centres are in dire straits. I mean, we had all consolidated, top-notch equipment. Our boards invested. And I do think that, and it was well said in the article, I think it was a Mr. Laycock, hope he doesn't mind me using his name, but he said it really well, that we have to wrap our head around getting the foundations in place, the fundamentals, so that the information can move. And I do think that's probably a little bit of a tension in the UK, because I have talked to some of my colleagues, they say they keep going to boards trying to get approval, which for things that to me, where I come from, is a basic necessity. Yeah. I don't know how else to say it, but to me, single sign-on for people pushed to the limit in care is a basic requirement.
There's a real disconnect between sort of the haves and have-nots, because we find that all the time. It's, it's hard to excite somebody about artificial intelligence and the potential of all of this stuff if they can't get access to a computer or a single sign-on or whatever. So I think that recognising the different starting points and that not everybody is in the same place. Everybody can make progress, but it's not all at the same pace is important.
And that's just to reiterate why having it locally driven is really important, because if you really have got this differences in maturity in different localities and they have different local clinical needs, that is why top-down really does not work, and it hasn't worked over the last 10, 15 years.
Okay, well, we're going to go to some questions from our audience, because they are flooding in, and we've got some really great ones, and we've talked a bit about some cultural barriers and started to touch upon some of the some of the policy issues. And I've got a question from Oliver Phelan at Versus Arthritis. And he's just asked if maybe we could speak a bit more about perhaps some of the other key policy barriers that are preventing the integration of health and social care data currently. So under James, could I perhaps come to you from your point of view, what you think some of the big issues?
I think barrier is a difficult word. I think I'd rather think of them as issues we need to talk about. So data security and cybersecurity is a fundamental. And I always come from a perspective that we want anybody that's involved in the care of a person to have access to that information. And I think that we've done great stuff in terms of the NHS. We have, and then with the Data Security and Protection Toolkit, which I know has been a big barrier for people to get through, and I think that's changed enormously. And opening that up to care providers in particular has been important, and making sure that it's accessible. So I think coming back to that, that's one of the biggest issues. I think if we are going to make sure that data is going to be shared, we need to know that whoever's sharing it is the person that should be, whoever's reading it is the person that should be reading it, and that's a fundamental, and that it's safe, and it can't be abused. And then on top of that, if we're opening up our systems, how can we make sure that they aren't subjected to huge viruses? So that's one of the key ones. I also think there is another area where particularly, I always come back to health and social care, so sorry about that everyone, where we need equity in the value of the information. So we talk a lot about health information being read by social care and that making a difference. I think there's a lot that health can learn from what's happening within social care. And that's not just old people, it's also people with long-term conditions, learning disabilities, mental health, all these type of issues. And I think changing that dynamic will also start to unpick some of these, trust issues about where that information is being received.
I think the word you just used at the end there, trust, is an awfully large barrier. For organisations to be able to trust each other, that they can effectively share information, and that it's going to be used appropriately. The way we know the barriers are particularly around just the way in which the health and care system is set up, which is also deep philosophical, in which is a bit of a rat hole that we don't really want to go down. But the problem ultimately is that for somebody, an organisation, to be able to go and do something, to allow information to be shared, often actually costs them money, or means they have to change substantially what they do. But they're not the ones who get the benefit. The ones who get the benefit are the other organisation who's going to receive it. So when they're looking to do things, they can, well, I can see it, but I'm not going to get thanked. We had a chairman of a trust say, if I go and help another organisation but it doesn't benefit me, I'm not going to get thanked by my board for actually doing that. And it's just, we need to just be aware of that. And that's why we've got to work out with trust and what have you, that there's give and take. And we work together to be able to do that.
There's a recent, and I apologize, I'm going to get the name wrong, but I think it was a social care document actually. And one of the big sections in it was around leadership. And your comment just triggered that for me. I think everyone working in healthcare, their number one priority has to be treating patients so they get the best quality and safe care. And so that section in the report talked about how we develop our leaders so they're doing the right thing. And this idea of, is my board going to give me thanks for that? I think there's an opportunity to educate boards in a different way. Probably why when Matt Hancock says we should have CIOs, CDOs, or whatever on boards to help get that message through that, this is what we're driving toward. It is holistic care for the citizens we serve, and regardless of where they live in the UK. And I think sometimes it gets lost that the amount of care people get in acute care is very small. Most of their interaction is in primary care, social care. The largest percentage of the interaction in health will be around that milieu. very small amount in acute care. So interoperability is critical so that those people outside acute care can deliver to that person in an effective way.
One of the other important policy drivers, I think, really helpful is getting the whole system aligned to be pulling in the same direction. So the recent announcements about NHS improvement and CQC starting to regulate and inspect in line with the standards, I profoundly believe that needs to happen, that we line up everything. So, you know, back to that cultural change and how do we make that shift to standards. If everything's pulling that way and is consistent, that helps a lot.
Yes, I think that's really a positive. 8 years ago in the Canadian accreditation system, it's very similar to CQC. Under the leadership umbrella, at that time I oversaw health information as well. There was quite a bit around access to information, how it was delivered, not duplicating information. It would come up every time they would come and visit around how we were making the information available to people. And you would not, you know, get an outstanding if you were not managing that digital space in the appropriate way. So I think when we talk about policy, having that at the CQC level, I often wonder, you know, one of the things should be, do you have a digital leader on your board? If you don't in this day and age, can't get outstanding. That's how bold I am about it. I just think we are in the digital age. The whole healthcare runs on digital. When WannaCry happened and some of those organizations were hit, I think it really resonated with people how critical now the functioning of the digital space is to run the healthcare system.
Absolutely. Oh. Well, we've touched a bit on citizens, so I'm going to go to our next question, which is from Tal Helbitz, who's at Barnet CCG and a GP board member, as well as chair of the digital board. And Lorraine, perhaps if I come to you first on this, how do we get the buy-in from the general public agreeing to share their data, and specifically from those who are not users of social care data?
Oh God, an easy one then. I think the points that have been made about this is, you know, a tectonic shift over time. One of the reasons in our process of developing standards, patients are first and foremost in that process. People, I should say, not necessarily patients. And all we can do is, you know, start with that and work away at this over time. So we've done a lot of work around educating people. They need to understand how their data is going to be used. I think some of the initiatives around patients taking accountability, access to their own records and so on, make a huge shift in their own right. So I don't think there's a magic bullet. I'm sorry, I don't have a better answer for that one. But I think over time, people will see the advantage of that. I was giving evidence at the Patterson inquiry recently and talking there about the impact of, you know, a patient having access to their records, about recording information on shared decision making, that kind of thing. So all of those things will help, but I think it's going to be gradual over time. Back to David's point on trust and how you build trust. But I think once it takes off, this will be unstoppable.
I think as well, I might add, I think we underestimate the public and we don't spend enough time. Lorraine, you just hit on something. There's a huge opportunity to educate the public. And I think sometimes us working in the system are complicit in creating this fear as opposed to going out and educating people around what the benefits are, also being open about what the some of the risks are. But most of the public is very much capable of making those decisions. They do their banking, they do all kinds of other things. And I can remember a number of years back doing a session for mental health group. We were going to move, when we were digitizing the record, and some of the clinicians didn't want the mental health notes in the record. So I was part of a group going out and doing public engagement. And all of the actual mental health group that were in that public forum said, no, we have an illness just like cancer. Why would you put us somewhere different? If I arrive and emerge, I want someone to know that I'm being treated for this illness, this. And when they travel, they wanted to have their digital information. That was a big moment at that time because it fundamentally shifted the decision making, and it came from the public. But prior to that, I was in charge of the project and the health record, and the amount of resistance I was getting around having the mental health record uploaded into the patient's record was pretty strong. And it was a learning for me that educating and working with the public is really important. And you have to trust that once they understand, they by and large make the decisions that are in their best interest.
And you can imagine that dynamic shifting then, can't you? And that they will, take accountability and drive that change and demand different.
It was one of those, you do something and it's a life-changing moment. There was one young lady and she said, I traveled last year, and she was in Australia, and she said, I had a real tough incident happen, and she went to the emergency department, and in Australia they were asking her for her memory stick or whatever, and she said at that time, so we were just early days, this is probably 2002, getting the electronic record rolling out, and we didn't have it. And she said, there I was, and they were in Australia trying to get to our health department to get the information. So she said, I want to know that when I'm traveling, I can get that information. I can take it with me, and I have my full record. So if something happens, I can give it to someone.
I think there was something else in that question, though, which is very, very important, because of both Lorraine and Shauna have talked about most patients absolutely want their information shared, particularly for the point of care. So, because of all patients still expect when they go to a GP or whatever, that the GP's got everything, or they go to a hospital, they've got everything, and they're surprised when they haven't. But I think the thing they're perhaps a little bit more nervous about is what happens when that data shifts somewhere and goes somewhere else to the proverbial centre or something, and they don't know what's being done with it. And I think that there's a level of distrust about that. What might my data be used for? Not helped by things like that's happened with care.data and things that have happened before that about what was going to be put on sort of summary care record and spine. And I think there is a level of engagement that needs to be done about that, because if we know that we do need to be able to manage aggregate data to begin to do proper population health management planning and that kind of thing. But I think we need to start where we can be successful, and that's exactly at the places that Shauna and Lorraine have been talking about. But I think that there is that other part of it which we still need to tackle.
Yeah, I agree with that. I think, and I really like bringing the examples real, but we're all familiar with concepts around minimum viable products. I mean, really we should start with saying, okay, this is the bare minimum that we want to start with, and really engage with people on how we share that and how we use that information. We can get overexcited, particularly in this day and age, in the speed at which we start to understand how our data is being used outside of perhaps health and social care, that we get, we could do this, this and this. I think we need to make sure that fundamentally we're supporting frontline care in the first instance, and then and get everyone used to that idea.
I do think that the education is pretty key. There's just something posted, it might have been in a survey that was just done with the public, and the caption in the article said, the public does not see the digital as important as Matt Hancock or something, and they said they want the money going to cancer care, whatever, and it struck me that those surveys can be difficult and if not misleading, because if you don't take the time to explain to the public, I don't think you can treat people with cancer in this day and age without good digital, information coming in. It's just too complex. I talked to a physician in a lab, and he said we're down to the level of treating by cell. It's getting that precise because cancer is different in everyone. So I don't think we've help the public understand. And I think in that survey, if they understood the power of the digital information to their care, to how it will enable us to be more effective, use the money more wisely, that the graph that was shown would be much different. And I think you have to be careful with those surveys.
Okay, so on to our next question. It's in regards to the third sector. and it's from Breda Spillen at City and Hackney CCG. And she asks, how does the panel see the contribution of the third sector in the care and ongoing support around maintaining well-being of patients, particularly in mental health, being included in this challenge? So Shauna, perhaps I'll come to you first. You mentioned one example about those living with mental health conditions wanting to be included.
Absolutely, and there's so much complexity around that. Often, with mental health, people suffering with mental health illness, they're relying on family and other members, and having access to information is really critical to have the support that they need. Again, with the right, approvals and all of those things in place. But I think if 1 in 4 is suffering from a mental health condition, how are we to say that there isn't a need to have that sharing of information? So those, not only the individual, but those supporting them can do it in the best way.
Yeah, I think that the question there about the third sector, I think, is taking us into another very interesting area, because we're often talking about, we've been talking about sharing of information so far really about helping people understand what's happened to a patient. But obviously the third sector and what they're looking to do with the ongoing management is how are we going to be able to manage that patient sort of from now and in the future as well, which is sort of beginning to get more into things like care planning and what have you. And we need to be able to have integrated care plans which are made up from the NHS, particularly primary care and community, social care, and the third sector. And are we really looking at ways in which we can do that? Well, I think we really start very early on a journey just around care planning for people in the community, and trying to integrate, primary care and social care. We absolutely need to be able to get our arms around that and begin to do things with it, and recognise that even the third sector has often got, may have very little IT estate, but we've got to work out and work through that, how we do it, if we're going to be able to address the continuing challenge of those long-term conditions.
And I think, not forgetting that a lot of adult social care is delivered by third sector organisations already. I think there's a really interesting debate which we could have a whole session on about where do we take unstructured data. And a lot of the information that will be held in those settings will be of that format. But I think even simple stuff where we can structure, like, has somebody that you're involved in gone into hospital, and are they happy for you to know that, could be a really changing point in terms of the efficiency of those quite fragile care and third sector organisations. If somebody's gone into hospital, they don't want to try and find them, knock down their door, those type of things. And increasingly CCGs, I know, are looking at social prescribing as a way of supporting people before they have a health episode. So I think there's another step in the journey to go, but there are some things that we could probably start doing quite soon in terms of very simple, explicit information, rather than moving down straight away to that unstructured information.
In a very simple way, in terms of how can the third sector be involved, when we're defining the content of an information standard, we're really keen to involve whoever's got valid views about what information is useful and will improve care. So particularly with the charities and so on, we've had great input, and we would really welcome that in future. And the other thing that strikes me is, as we move to more of a well-being culture rather than fix the illness problem, I think that will become increasingly important, and the care plan examples and so on that have been talked about, I could see that having a bigger role.
There's a great example, the This Is Me. I don't know if anyone's heard of that, where actually it's moving away from some of the information you're using about, actually, if you're delivering my care, there's some things you need to know about me. And a lot of that information is supported by people working in third sector organisations. I think that's a growing body of evidence around that's being helpful in care settings.
Excellent. Well, James, I'm going to come straight back to you for our next question, which is from Simon Everingham from Baxendale. And Simon says, I agree that understanding where social care organisations are at with their digital maturity and their suppliers is key. Would you say this is the same with community health providers?
I don't think I can answer that question. I'm not a specialist in that field, so I'm sorry. Yeah.
So is this perhaps what we identifying perhaps an area in community health where perhaps more needs to be done to see the role that organisations can play? Because you don't see much about community health in this agenda currently.
Yeah, the received wisdom is always that social care information tends to be less structured, less available, and I think also that's true. I would have thought to a slightly lesser extent in community care, but I don't really have the evidence. The example that I was giving earlier about the integrated paediatric care plan was a community example. So, again, I would say there are good examples and there is good practice happening and steps that can be taken, for everybody can progress on that journey.
What I would say, if it's community health being provided by the NHS, then any system supplier working within that has to comply to the NHS contract. So there are ways in which we can have the conversation, even though as a provider you might say it's a blunt tool, but it's a different situation in terms of that supply relationship than we do have in social care.
Well, perhaps a future area for the King's Fund to look into in that case. So I've got a good question here from Ronan Fox, who's B&D CCG Children's Commissioner. And Ronan says, just about to launch an interoperability transformation project in my STP area. What are my top 3 starting points in the panel's view? Lorraine.
I'll start with 1, 2 and 3. Yes. Involve the clinicians and the other professionals who are involved and patients. It's the technology is important and necessary and needs to happen, but approach it as a cultural change program. If you get those people leading it and championing it, you're there.
It's a transformation program enabled by technology.
Yeah.
So definitely one thing. Second thing, in my experience, too often, as a supplier, we've gone to see organisations, whether they're STPs or what have you, wanted to be able to talk about what our software can do and what have you. And then you ask them, well, have you kind of got your information sharing agreements in place? Have you thought about that and your governance and how you're going to do it? And they go, well, no, not yet. And you feel like saying, well, look, come back when you've kind of sorted that out, because you won't be able to really do anything at all until you've done that. So you really do need to think about what's the information sharing and how get your agreement sorted out and get your governance for your program sorted out as well. And with the engagement of the clinicians, you're then going to be able to focus on what's the first problem we want to solve, because if you're not going to boil the ocean, you're just going to start with something and go and fix that and then try and grow out from it.
Can I offer a third? A bit practical. I really agree with both of those. And partnership on
Partnership, yeah.
Just have line up your contracts. You work out where all your partners are in terms of their procurements and their contracts for IT suppliers, and when they're going to have their upgrades and all those type of things. Have that for the next 7 years laid out in front of you, because those things can really pull the rug out of what you're trying to do. You suddenly the mental health pops up and say, oh, forgot to tell you we're not to pick on mental health, sorry, but we're recommissioning our system, and then it doesn't work out in terms of the person that you've been working with to date. And so I think just having awareness of where those are would be really sensible.
I would agree. And add to that, it's critical managing your suppliers.
Absolutely. So, on to our next question from Ben Panton, AGEM CSU Transformation Project Manager. To what extent does the panel feel progress, or lack of it, has been made in the second component of interoperability, namely presenting data so it can be understood and used by the end user? It has to be much more than just the exchange and sharing of information data. Usability is key. I think we'd all agree with that, but what do we think about the progress around this around the sort of the advanced stages of interoperability.
I'll chip in on the usability bit. The other bit, I'm sure, is much more David's territory. I think as more information starts to flow and be shared, something that's really struck me in a meeting last week with one of the Lycra site in Wessex is much more information flowing, being shared across lots more different sites, different people. How the interfaces work is going to be really, really critical. I can really see the day where, at the moment, if there's a CQC report or investigation or whatever, it's because there aren't any records or, a dearth of records. You can just see the day in the future where it's because we were overwhelmed with information. So thinking now about how is information presented, how can vendors help get those interfaces really work and present the information that you need at the time is going to be key. But I think there's a harder question underlying it as well.
Yeah, I mean, to directly answer Ben's question, yeah, it's disappointing. But then, I think we've all discussed what the issues are and the obstacles we need to overcome. I think the thing we need to look at is going forward. If we've recognised what those are we doing things differently to allow us to be able to get there? And we are now, I believe, going down the right road. But to be able to get to the stage where, systems can not only exchange the information, but a receiving system can begin to understand and reason on that, which I think really is what Ben is talking to. That not only relies us to be able to exchange structured data, it needs to be coded with meaning, which means we need to have SNOMED. Now we are still some way away from that. But the point is that what we're building today with the interoperability standards, it doesn't rely on SNOMED. We can start to do things, but it is built for SNOMED. So when SNOMED comes on board, we can then do it. But then also still got to realise that the system suppliers have still got their own decisions to make as to, well, they're used to being able to validate information that comes into their system when it's typed in via the UI. If they're going to be receiving information from another system and their system itself is expected to reason on it in some way, have they got to be sure about the quality of that data, that it is clean, that they can do those things with it? That does begin to open up sort of some questions as to, are suppliers happy to do that? And does there need to be some quality assurance around that? And I think we just need to think about that, and we need to work through that. I don't believe that is insurmountable at all, but we need to be able to address it. But again, to what Ben is asking for, that is exactly where we need to get to, is to that level, and we're going down the road.
Okay, on to our next question, which is from Jacqueline Clay at West Sussex County Council. And Jacqueline asks, in terms of health and social care data, if anywhere in terms of social care data, is there anywhere in the UK where you might cite a good practice or trailblazers in terms of information sharing that others might learn from? Good examples that we've come across at all? Is it too early to...
Pretty good. I think there are some really strong exemplars where we're sharing local authority social care data with health settings. If you look on our website, social care programme NHS Digital, you can see some of the areas we're working with where they're doing exactly that type of thing, but they're quite piecemeal. There are less examples where we're talking about data sharing direct with care providers. It's much more about document exchange at this point, but there's a lot of progress in this area.
I would agree. I was just thinking off the top of my head, Southampton, a couple of the GDs are doing some really great work. Southampton is doing some good work and sharing information across systems, even with their patient health portal. I believe, if I'm correct here, Manchester is starting to do a fair bit around sharing of information. So I think there's pockets of it, and it again coming from, my question was what's different now? I think people are really getting on board and seeing the value and trying to make a difference.
Yes, and Manchester came through as a comment from one of our audience watching. Got another top tips question for the panel, which comes from David Atwood at the British Geriatric Society. And David asks, what are some of the features of a good information sharing agreement? Are there any recommendations that we can give to David and others about a good starting points, even just the basics?
What are the outcomes are you trying to achieve through the sharing of the information? You know, having all of your key stakeholders agreeing that from the very first instance is the most important thing. I think you need to understand why and start with that one.
Yeah, I think the information sharing agreements here with what you're trying to achieve is setting a statement about culture as much as anything else. You know, so that are you able to say every single item of data has got to be in this information sharing agreement that we're going to share? No. But what it means is if you've got something which is saying this is what we're trying to achieve and what have you, if somebody has shared some information, if you can point back and say, well, I shared this information, we're doing this, because it's allowed us to achieve this particular vision, you know, somebody must feel more comfortable that they're doing the right thing, you know, even if, for the want of a better term, they haven't got the explicit permission to do it. You know, their patient will have said, I'm happy to share this. I think that's important to be able to have that. You do need to be able to define who the organisations are. You do need to be able to describe the categories of data. What is really important, though, is if there are specific things you're going to exclude for certain things, you need to say those. And that's probably an easier way to start, is saying what is going to be excluded rather than what's going to be included. But I completely agree with James. Line up, it's the organisations and what are we trying to achieve, I think is a really important thing to get clear and buy-in from all those organisations.
Yeah. So they sound very sensible to me, but you know, I don't know what are the best things. And my feeling is that's the point. I don't know, and it feels like there's people all over the country grappling with the same problem. And I know as part of the local health and care record programme, the information governance piece is a really big thrust within that, which I think is exactly what we need. Some wheels we don't all need to be reinventing, and it feels like there's a need to cut to the chase, cut through all of that and help people, you know, so we're spending our energy on more productive, creative things that really do need to be done locally.
I'd also say make it a living document. Make sure that it's something you go back to. Don't put it on the shelf and say, oh, we've got that in place, we can do everything. I think it's worth, if you want to keep that culture going of openness, of making a regular point of doing it, and make sure that there's something at the top of it that everyone can understand, because when we really get into the detail it gets very technical, and it needs to be, but have something at the top that, you know, people around a board table can sit and read 5 minutes, okay, this is why we're doing it.
Okay, so I think we've got time to squeeze in one last question from our audience, and Shauna, I might come to you first on this one, and this is from Hannah Laidley, who's at University Hospitals of Leicester and is a Foundation Year 2 doctor. And she's asking in terms of, are there any other countries in the world that have achieved a solution we can emulate, or perhaps any other systems? And we've mentioned Australia, Canada, and the US as well. And if there is this disparity at the moment in England, is there anyone out there that we can look at as really good examples of how to emulate what they've been able to achieve?
Yeah. Someone else would correct me on this, I'm sure, but I remember, I think it's Korea, South Korea. They have a very connected system there. Canada's come quite a long way with Canada Health Infoway driving the standards. When you mentioned SNOMED, I was involved in a project probably in 2008 where we decided at the health authority I was at, driven by the physicians, that we would do all the cancer operative reports using SNOMED, and we created those templates, and they had to follow that standard. So a lot being done there. Some of the Danish countries as well are moving along with interoperability. So I would say in the Netherlands they've done some good work with that. I don't know if you guys are...
I would say that a country that does do very well from an IT perspective and is pretty connected of all in Europe is Spain.
Yes.
It's helped by the way it's organised though, because it's very regional and the regions then have the control of what goes on. A lot of the issues that we have are things we've alluded to already about just the disparate nature of the NHS and it being being a brand and not a single organisation. But Spain is good. Now, Spain is using some older standards for interoperability, which goes to show it's not just about technology. It is about alignment. It is about all these other things which we've spoken about. But I would say that Spain is a good thing is a good country to look at.
I might add here, not to overlook, I'm interested, and I was just at a Gartner symposium, and someone from the Scottish healthcare system was presenting, and I believe that they're going to have a good run at it because of the way they've structured their decision making and how they're trying to connect everything, and the way they've made decisions around their system, as they call it.
I always think it would be really easy if we were starting with a blank page. It'd be a doddle, wouldn't it?
Yeah.
And that's the problem, that we're not. So I think there's some fabulous examples out there, but it is those pockets. I don't think anybody's got the lot joined up yet.
But it is about then working out how you can apply that to England or whatever country who people are from, because of the way the systems are set up, i.e. the health system as a whole are different and the way the money flows is different.
I would agree with that, and it's always important to remember the size of the Scottish population. It is, scalable. I don't think we've yet really seen the full benefits of something like the NHS number. A single patient identifier as a very simplest piece of interoperability is still not used everywhere. And I think there are some things that we could probably really focus on to push forward.
That was one thing that I found challenging to get my head around coming here, because I come from a health authority that it was a requirement to use your, you had a unique identifier in your health card and you had to use that number. I couldn't believe it when I came here that wasn't like a mandated thing.
I still can't quite believe it, to be honest with you.
I keep thinking, why is that? It's mostly mandated in pretty much every Canadian province. You have to use your unique healthcare number.
Well, unfortunately, we're very short on time. I could probably keep you here for another hour with all these fantastic questions, but I won't. So starting with you, Lorraine, could we just ask everyone for some brief final words on the discussion?
Gosh, there's so much. I think for me, the reflection is the one about, it's really reaffirming. It's great to hear all of the people around the country, beavering away at this themselves. I think it's sort of hold faith. It's the right thing to do, but kind of it's okay to go a step at a time, just so long as we keep moving forward.
James?
I was going to say something very, very similar, I'm afraid. I think it's about making sure we're using a story and a language that everybody can understand, but taking it a step at a time and making sure that those steps add value as we go.
For me, the reflection is that what an exciting time to be in healthcare, and you're seeing so much collaboration across the jurisdictions. You're seeing wonderful opportunities come from the private sector that's pushing innovation. And so for me, I think we are on the edge of really fundamentally changing how healthcare is delivered. And how great to be a part of that.
I think I would say try and take control of what you're trying to do in interoperability and don't wait to have interoperability done to you by sort of the centre or what have you. You know what your local priorities are. You do not have to be able to go into something, high tech. Do something which is good enough that allows you to solve a clinical problem and allows you to then go forward from that.
Excellent. Lorraine, James, Shauna, David, thank you very much for joining us. And thank you to everyone who's joined us online. Thank you to those who submitted questions and comments. I do apologise we didn't get time to go through all of them. There were some fantastic ones I would have loved to ask with more time, but there was a huge amount in there. But we will share them with our speakers so that they can see the kind of things that you are asking. And if you've enjoyed this our online event half as much as I have, I'd encourage you to look at some of the past online events. They're all available on the King's Fund website. And also to highlight our next online event that is taking place on Wednesday the 5th of December, which will focus on the emerging topic of the NHS estate and technology. And finally, if you're interested in partnering with the King's Fund on a future online event, I'd encourage you to get in touch with me, either through asking a question on the portal or email me at k.cornwell@kingsfund.org.uk. Other than that, that just leaves me to say thanks for stopping by. Take care.